Hello and welcome. Today we're diving deep into a serious eye condition called suprachoroidal hemorrhage with intraocular pressure elevation. We'll explore what it is, what causes it, how it's diagnosed, and the available treatment options. This is crucial information for understanding this potentially sight-threatening condition. Suprachoroidal hemorrhage, often abbreviated as SCH, is caused by bleeding into the suprachoroidal space, which is the potential space between the choroid and the sclera, the white outer layer of the eye. There are several risk factors that can increase the likelihood of SCH. These include advanced age, pre-existing glaucoma or other eye diseases, myopia or nearsightedness, and systemic conditions like hypertension, cardiovascular disease, and bleeding disorders. Eye surgery, particularly glaucoma surgery like trabeculectomy and cataract extraction, is a significant risk factor. Trauma to the eye can also precipitate a suprachoroidal hemorrhage. The pathophysiology of SCH is complex. Basically, it involves the rupture of choroidal blood vessels. During surgery or due to trauma, or even spontaneously in susceptible individuals, these vessels can be damaged. When this happens, blood rapidly accumulates in the suprachoroidal space. This accumulation of blood pushes the choroid and retina inwards, towards the center of the eye, causing a sudden increase in intraocular pressure, the pressure inside the eye. This elevated pressure can further compromise blood flow to the optic nerve and retina, potentially leading to vision loss. The hemorrhage essentially acts like a space-occupying lesion, disrupting the normal anatomy and physiology of the eye. Determining the exact epidemiology of suprachoroidal hemorrhage is difficult because it is a relatively rare event, and precise incidence rates vary depending on the population studied and the surgical procedures performed. However, it is estimated that SC occurs in approximately 0.2% to 2% of intraocular surgeries, especially in glaucoma patients. The incidence is generally higher in older individuals and those with underlying risk factors. Certain surgical techniques and the surgeon's experience can also influence the occurrence rate. Large-scale studies are needed to more accurately define the global prevalence of this condition. The signs and symptoms of suprachoroidal hemorrhage can be dramatic and alarming. Patients often experience sudden and severe eye pain, a rapid decrease in vision, and sometimes a sensation of pressure or fullness in the eye. On examination, the ophthalmologist may observe a shallow anterior chamber, the space between the cornea and the iris, and significantly elevated intraocular pressure. A dark reddish-brown mass may be visible through the pupil, representing the blood in the suprachoroidal space. In some cases, the cornea may become cloudy due to the high pressure. These are all critical indicators requiring immediate attention. Diagnosing suprachoroidal hemorrhage involves a comprehensive eye examination. The ophthalmologist will measure intraocular pressure, assess visual acuity, and perform a slit lamp examination to visualize the structures of the eye. B-scan ultrasonography is an invaluable tool for confirming the diagnosis and assessing the extent of the hemorrhage. It allows visualization of the suprachoroidal space and the degree of choroidal detachment. In some cases, computed tomography or CT scan or magnetic resonance imaging, or MRI, may be used to rule out other potential causes or to further evaluate the extent of the hemorrhage, especially in cases involving trauma. Suprachoroidal hemorrhage can be broadly classified into two main types: expulsive and delayed. Expulsive suprachoroidal hemorrhage occurs intraoperatively, meaning during surgery, and is characterized by a sudden, forceful expulsion of intraocular contents due to the rapid accumulation of blood. This type is often associated with severe vision loss. Delayed suprachoroidal hemorrhage occurs days or even weeks after surgery or trauma. It is usually less dramatic than expulsive hemorrhage, but can still cause significant complications and vision loss if not managed promptly. The treatment and management of suprachoroidal hemorrhage depend on the severity of the condition and the timing of the diagnosis. Initial management often involves lowering intraocular pressure with medications such as topical or oral glaucoma medications, including beta blockers, alpha-adrenergic agonists, and carbonic anhydrase inhibitors. In severe cases, surgical intervention may be necessary. This may involve a vitrectomy, which is the surgical removal of the vitreous gel from the eye, along with drainage of the suprachoroidal hemorrhage. This procedure aims to relieve pressure, restore blood flow to the retina and optic nerve, and improve vision. Careful monitoring of the patient's intraocular pressure and visual function is essential during the recovery period. While it's impossible to completely eliminate the risk of suprachoroidal hemorrhage, several strategies can help to minimize it. Careful surgical technique is paramount, especially in patients with known risk factors. Meticulous control of intraocular pressure during and after surgery is crucial. Preoperative assessment should identify patients at higher risk, allowing for tailored surgical planning and preventive measures. For patients with systemic conditions like hypertension or bleeding disorders, optimal management of these conditions can reduce the risk. Educating patients about the signs and symptoms of SCH and the importance of prompt reporting is also vital. The prognosis for suprachoroidal hemorrhage can vary significantly depending on the severity of the hemorrhage, the timing of treatment, and the presence of underlying eye conditions. Early diagnosis and prompt intervention are crucial for maximizing visual recovery. While some patients may regain good vision, others may experience permanent vision loss. Recent research is focusing on developing new surgical techniques and pharmacological agents to improve outcomes. For example, studies are investigating the use of anti-VEGF medications to reduce neovascularization, or new blood vessel growth, which can occur as a complication of SCH. Continued research is essential for advancing our understanding of this challenging condition and improving patient outcomes.